patient hearing, and I'm
to FMC Pune for I hope that you can see my slides okay. I don't know, it's jumped from the first slide. Let me try to go back to the first slide. Okay, so you mentioned that other people have talked about the link of cardiovascular events in relation to some of the other treatments in diabetes. Yes, that is certainly a factor, and I think an important factor in the reduction in the risk of cardiovascular disease with some of the newer drugs. But having said that, we still often have to use insulin in people with type 2 diabetes, and that does increase the risk of hypoglycemia, as you know. Surprisingly, we've known for many years hypoglycemia causes a lot of distress and difficulties for patients, but the risk associated with cardiovascular disease has only recently been appreciated in the last 10 or 15 years. And I'll show you some of that data in a moment. First of all, let me define what we're talking about with hypoglycemia. There are many definitions about it. This is the most recent from the ADA, which gives levels. Level 1 hypoglycemia being less than 70. And the reason for that is that you often get and set to get an alert on CGM, etc., is that this is the threshold for activation of counter-regulatory hormones such as adrenaline and glucagon, etc. So the body is sensing that something is going wrong. And as we will discuss later on, this counter-regulation is involved with some of the pathophysiology of cardiovascular disease. The second issue is the cognitive impairment, and that can occur at different levels in different people, but they've set a level of 54 because it's 3 millimoles per liter. And level 3 is classified as a severe event involving altered mental status and requiring treatment. There are some previous definitions that I think are a little bit more descriptive, and it may be important, particularly defining severe as needing the assistance of another person. There's another category, which I think is fairly frequent, and that when people have probable symptoms of hypoglycemia, but they don't measure it. So do we not classify those as hypoglycemia? I think we should, at least in clinical practice, maybe not in research-related things. So hypoglycemia, at whatever level, has a lot of impacts on the patient. It affects quality of life, work productivity. There are a number of studies showing these. But the importance is that it leads to changes in patients' behavior, different uses of maladaptation to this in behavioral terms of not titrating their dose, overeating, more weight gain, and increased cost. But the real problem we are addressing today is the increased morbidity and mortality, particularly cardiovascular disease, but overall mortality also being associated with this. So this is an old paper, one of the early ones to point out that hypoglycemia is very common in type 1 diabetes and is also common in type 2, but it's less frequent than in type 1. So here is a more recent paper, more generalized population in the US, talking about how often people get hypoglycemia. And in type 1, as you can see, it is very, very frequent, occurring in 60% of people at least once a week, maybe more often, and in type 2, almost 25%. And now with continuous glucose monitoring, we're recognizing that asymptomatic hypoglycemia down to levels below 50 are occurring quite often. And some of this occurring at night or when the patient is somewhat vulnerable and events occur. And we are using more and more of continuous glucose monitoring to recognize this phenomenon. And here is one study showing, this is an early CGM study showing this is fairly frequent, just like with the other ones, but maybe more frequent in type 2 diabetes. Now, people who have a lot of fluctuations in their blood glucose due to treatment that's not right, or behavioral factors tend to get more hypoglycemia. And that's not also surprising. If you're going to be fluctuating up and down a lot, you might overshoot and get hypoglycemia. The big problem is people are often unaware of their hypoglycemia. And this is very common in type 1 diabetes, but increasingly happens in older people with type 2, particularly if they have neuropathy. We also recognize that there are many risk factors for hypoglycemia. Long duration, as I mentioned, cognitive impairment itself can induce hypoglycemia, neuropathy because you don't recognize it, and other comorbidities, particularly hepatic and renal dysfunction. So sometimes there are self-management issues, medication overdose, taking prandial insulin and not having meals, exercise that's unusual at an odd time of the day without adequate nutrition, etc. So many years ago, we were among the first to describe a very interesting phenomenon that looked at people who had started insulin therapy in the VA population and had an episode of episode of hypoglycemia within the first 3 months. And then we tracked that and compared them with a control group who also started insulin, but did not get hypoglycemia in the first 3 months. And here what you see is that those who had hypoglycemia had more cardiovascular events. Now, is this due to hypoglycemia or just a marker that these people have comorbidities and other problems is not clear, but I think it is the latter. But it's very clear you're identifying a marker of future risk of cardiovascular rate. Big difference in rates of these events, particularly over the 2 to 3 year period. And a lot more seems to occur in people with known cardiovascular disease, as you can see from this study. Now, whether this is because these people are sicker with other comorbidities is also not clear from this population. Clearly, renal insufficiency and other comorbidities make it difficult for people to manage their diabetes well, and they also tend to have more hypoglycemia. Now, there's an increased risk in people with, people who have coded for hypoglycemic events. They also have very frequently increased risk of cardiovascular events, coding sometimes 10 times more. By coding, I mean documentation of both the diagnosis of hypoglycemia and a cardiovascular event. So here is another study from the Scottish group, Dr. Freer et al., who've done a lot of work in this area. And they looked at cardiovascular events in type 1 diabetes. And in people who have had more than one previous episode, their risk is 1.9. And in people with type 2 diabetes, it is 1.5. Perhaps there are other factors in people with type 2 diabetes, such as age and obesity, etc. This problem really came to the forefront with the ACCORD trial, where the trial, as you know, intensive therapy was stopped early because of an increase in mortality. It occurred actually in both groups, the standard group and the intensive group, and I'll go back into that breakdown. But it was associated this occurred more in people who had prior hypoglycemia, so they were dying more frequently. The ORIGIN trial was another insulin trial, and they too also noted that there was an increased risk of mortality, although the mortality rates were much, much lower in people who had hypoglycemia. As you are aware, there are other studies such as the ADVANCE study, the VADT. These were all done at the same time in different populations, and they all showed the same thing of increased mortality being associated with hypoglycemia. Now, the question is, are these people actually dying from hypoglycemia? And the answer is no. They're not immediately dying from hypoglycemia where the blood sugar is dropping just too low and the patient doesn't recover. Some of those increased deaths and events are occurring 2 to 3 years later. Now, that raises the question is, why is that happening? What is hypoglycemia doing? And we'll talk about some of the mechanisms later on, but I think an important issue in relation to this is that hypoglycemia is a marker, and it may tell you your patient's ability to recover before the glucose drops below 70, such as renal impairment, impaired hepatic and renal gluconeogenesis, etc., are contributing to their cardiovascular events, and it's just a marker there. And here's a meta-analysis of all these cardiovascular outcome trials that I pointed out to you. Those are at least randomized trials, but there's also a number of observational studies and retrospective studies, non-randomized, population-based, very large numbers, showing very much the same thing. So this meta-analysis is important, although it's mixing the two groups, which I don't particularly like, but it's got almost 1 million people with at least 1 to 5 years of follow-up. Let me just go back to the ACCORD trial, because we learned a lot of lessons there. If you look at hypoglycemia rate, it is obviously much, much more in the intensive treatment group than in the standard group. Remember, our aim for intensive treatment was to get the A1C below 6%. And I think nobody's really chasing that anymore with insulin. Maybe if you achieve that with some of the newer drugs, that's great. We also identified other factors involved in hypoglycemia, such as renal disease, African Americans, more in women, more as you get older, but high BMI with obesity being protective, maybe because these people have better body stores of nutrition. There are obviously patient-related factors, such as delayed meals, etc. That's not surprising, but it's not surprising in this population as well. What is interesting is that the risk of hypoglycemia didn't just occur in people who were well controlled. In fact, there were a lot of people who tolerated A1Cs of 6 very well. It was the people between 8 and 9 in both the intensive and standard group who had more hypoglycemia because we were trying too hard, and they were maybe sometimes not taking their insulin, so the A1C was high, and then they took too much and went low. And if you break it down into groups, and I won't spend much time on this, it occurred more in people who mortality was higher in people in the standard group who had hypoglycemia. So I think it's very tragic that people have A1Cs of 8% and have hypoglycemia. That is another population at increased risk of mortality. So it's counterintuitive, but although intensive control does increase the risk of hypoglycemia, poor glycemic control also has a great risk of hypoglycemia, irrespective of what treatment you use. Now, as Dr. Nauk pointed out, this all changed when we started using GLP-1 receptor agonists. And you've seen the cardiovascular outcome trials, and clearly in the GLP-1 and SGLT2 treated groups, the hypoglycemia events are less. Now, does that mean that that is the mechanism? I don't think it's the only one, but certainly may contribute. The same thing is seen in people who are inpatients. So I want to spend the next few slides talking about inpatient hypoglycemia, where the responses and the severity and the problems and the end result is very similar to what happens with hypoglycemia. We all say hypoglycemia in hospitalized patients is bad, but so is hypoglycemia, because you get aggravation of ischemia and adrenergic responses and more oxidative stress, etc. So many early studies, particularly from cardiac patients, showed an increase in mortality in those whose lowest blood glucose in the hospital was less than 3 millimoles, almost doubling. So the relationship between blood glucose and death from myocardial infarction is actually J-shaped. The higher you have your glucose, the greater the mortality, but the mortality is very greatly increased in people who have low blood sugars. Here's another way of looking at the same thing with another study. So what's the mechanism? And a number of mechanisms have been proposed. I'm going to show you some data in a moment. They showed QT interval prolongation, decreased perfusion, endothelial dysfunction, increased coagulation, and etc. But before we go there, let's look at the physiological response to hypoglycemia. The first thing that happens when your glucose drops below 80, actually in a normal person, the first line of defense is to decrease insulin secretion. Now, you cannot do that when you've already injected insulin or you've taken a sulfonylurea. You can do that with GLP-1 receptor agonists, because that is the action and is glucose dependent. The second is an increase in glucagon, then and around the same time, an increase in adrenaline. You get other responses later on with rise in cortisol, etc., and you start feeling hungry as it drops even further. But this is really the point we need to focus on. Are these things contributing to the events? Also, the brain may adapt to these changes. So brain function is changing, and you get further changes in autonomic function, which might be important in regulation of cardiac function. And I'll elaborate on that in a moment. So here are some studies that have been done looking at hypoglycemia and inflammation. So they did clamp studies, keeping people either euglycemic or hypoglycemic, and they looked at adrenaline increase, and that was very clear. But when they looked at markers of inflammation, such as selectin and markers like PMA, etc., they are clearly going up during hypoglycemia. Here is a study specifically done in normal controls and in type 1 diabetes. And you see the similar kind of things happening during hypoglycemia, that you are getting an increase in adhesion molecules like VCAM, selectin, PI1, which is involved in the fibrinolysis process, and inflammatory agent IL-6 going up. Now, this goes up in both normal individuals as well as in people with diabetes. So it is not something related to diabetes. It is related to hypoglycemia. Also, cardiovascular, this is a test of autonomic function. They are very good predictors of reflex tests and tests of autonomic function and its regulation of endothelial function, and they're good predictors of mortality. And here's what happens when you have hypoglycemia. Your autonomic function is impaired. When you have little earlier had hypoglycemia, you're unable to change your baroreflex sensitivity, and your output of sympathetic frequencies are altered. And this is another study pointing out the same thing. And you have an impairment in the longer term sympathetic and norepinephrine responses, but you can still get the burst at times that might lead to hypoglycemia. We did a study very early in 2002 when CGM first came out, doing Holter monitoring and glucose monitoring simultaneously. And we found in this population about 54 episodes of hypoglycemia, 10 of which were associated with chest pain. These were people with known cardiovascular disease, mainly type 2 diabetes. And 6 of them had ECG abnormalities. And some of them were symptomatic, some were asymptomatic. We also noticed a little bit of such events in people who had hyperglycemia, but it was a lot less. What was interesting was people who had rapid changes in their glucose, dropping by around 100, not necessarily dropping below 70. So say you go from 200 to 100, you had a greater risk of having chest pain and ECG abnormalities, suggesting that this can be just fluctuation in blood glucose, and a drop can change it. And here is one recording. This is a single case. It's cerebrovascular disease, and he had simultaneous Holter and glucose monitoring. And you see here he has hypoglycemia during the night. And around the time of that, if you go into more detail on his Holter, you see the start of ventricular tachycardia, just 3 beats. But if that hypoglycemia had continued longer, it's possible that he may have gone into prolonged ventricular tachycardia. So ventricular arrhythmias have been shown in other studies to be more frequent in people who have severe hypoglycemia, particularly in people with type 2 diabetes and CVD. It's very hard to document ventricular tachycardia, but triplets are almost likely to be a precursor to going over and progressing to ventricular tachycardia at some point. Here's a study looking at the QT interval, the corrected QT interval being prolonged during hypoglycemia, and then during recovery, it comes back down. There are other EKG changes that are described: amplification of the R wave, decrease in the ST segment, flattening of the T wave. All have been described in a variety of papers. And we summarized all this in a review article, Cyrus D'Souza and myself, showing the wide range of things that go wrong with hypoglycemia: decreased vasodilatation, increased inflammation, platelet activation, coagulation, and rhythm abnormalities, as I have shown you. So what do we do for patients? Let's get to something more practical. First of all, I pointed out the factors that make your patient at risk. So we need to assess patients' risk for hypoglycemia. We need to determine whether they have hypoglycemia or not. Now, that's a very hard thing to do unless you test more often. But today, even with professional CGM, blinded professional CGM for a couple of weeks, you'll be able to know whether your patient is getting asymptomatic hypoglycemia and therefore hypoglycemia unawareness. And just raising the glucose targets and the A1C targets may help overcome hypoglycemia awareness in some people. Also, any neurological symptoms are suspect, and neuropathy obviously is more commonly associated with this. And then there are strategies to prevent hypoglycemia. There are recommendations from ACE to do more frequent monitoring, use more flexible insulin regimens, and provide some ongoing guidance and support to your patients. The ADA also has similar recommendations: avoiding aggressive targets, adding carbohydrates before exercise, and also limiting alcohol intake. We should educate all our patients to treat hypoglycemia promptly. The 15-15 rule is check your blood sugar, eat 15 grams of carbohydrate, and wait 15 minutes and then check it again. And if it isn't right, repeat this whole process. Now, what has really changed our management of hypoglycemia and led to prevention of hypoglycemia as well, with a lower A1C, is continuous glucose monitoring. And here's a summary of some of those studies in type 1, showing a reduction in hypoglycemic rates in people with both high A1C and low A1C. And this has really been a game changer in this respect. There are also better treatments. Previously, you had to draw up the glucagon. There are now pens that are available, ready to inject. Some of them do require refrigeration, but there are now newer pens that are available that are pre-filled liquid glucagon. You don't need to mix it. It's a pre-filled syringe with an auto-injector, so very easy to use. And now you have a nasal powder for single use. This is very rapidly absorbed. You can take it during suspicion of hypoglycemia if you don't have time to test. And in fact, even in an unconscious patient, it can be administered by a relative. So it is more expensive, but we are using this in a number of people and found it to be very, very useful. And another form of glucagon called Desi glucagon has been developed, which is water soluble, which might allow this to be used in dual chamber pumps, the true artificial pancreas. So that is on its way. So in summary, hypoglycemia, both mild and severe, is associated with an increased risk of cardiovascular events and mortality, and should be avoided when possible. We would obviously try to use more of agents that don't cause hypoglycemia in cardiovascular patients, but inevitably some people will need insulin. They impact quality of life. It may be a barrier to reaching goals that we want. It's a clear predictor of events, so you treat those as high-risk patients. People get hypoglycemia, be more aggressive with their lipids and blood pressure, and maybe avoid future hypoglycemia. So the underlying mechanisms are unclear, but there are some that have been identified, and maybe we should be addressing those as well. So I'll stop there and be happy to take questions.